when we're going to reach for a parenteral analgesic, you're faced basically with two classes of drugs. You're faced with the narcotics, which work great, but they have some downsides. They have nausea, they have some hypotension, they have addictive potential, they have the flushing, but then you are left with who doesn't really need a narcotic, but wants a pain shot, whether or not you may think they need one or not, and so you're left with Toradol. And Toradol has a very special role there, and so we choose it a lot, whether we want to or not, and so we should know a lot about this drug because it's something that some of our colleagues give more than others of us. There are those Toradol lovers in every department that give Toradol to just anything. Give it to chest pain, let's see what happens, let's give it to everything. And then there are those of us who are a little more cautious about it, but we want it to be so much more than the NSAID that it is, I think, because it's a special category. When we teach the residents in our program about pharmacology and talk about drugs, the fact is there's so many drugs out there to know now. And, in certain classes like hypertensives and hypertensive agents and anti-epileptic drugs and antibiotics, there's so many things to know. We try to tell them, listen, you got to pick a few drugs that you know really, really well, know a lot about them. Those will probably be the drugs that you use 70% of the time. And those are the ones you really need to know. And Ketorolac is one of those drugs, I think, that we need to know a lot about the side effect profile and what it does and doesn't do, because it's something that we reach for a lot. The introduction to this chapter points out that if you're choosing to give intramuscular Toradol, the charges can be up in the hundreds of dollars if you consider the charge for the drug and the charge for administration. And the question that's posed is, wouldn't you be better served giving ibuprofen 800 milligrams orally, which maybe costs $2? Are they equivalent? How come we choose one more than the other? And so let's look at some of the data that tells us the evidence about our choice of Ketorolac. Does it justify its widespread use? Is it faster? Is one of the questions. Certainly in a patient that's vomiting and can't tolerate oral medication, you're going to choose an IM or an IV NSAID if that's really what's appropriate for that patient. So there's some areas where it's definitely appropriate. Certainly Ketorolac is not more potent than any other NSAID. There isn't any really ranking order of efficacy of NSAIDs. There are certainly individual differences. Some people do better with one NSAID than another, and we all see that. Someone says, that ibuprofen doesn't work for me at all, so we choose to try naproxen or try something else. And certainly there are differences with how individuals respond to different NSAIDs, but there definitely is data about the ranking order of side effects when it comes to NSAIDs, and Ketorolac is one of the worst in terms of side effects. We'll talk about GI bleeding, we'll talk about renal failure and how Ketorolac does compared to some other NSAIDs. Paper number 1 reviews the efficacy data of all different administration routes for Ketorolac. It's called Analgesic Efficacy of Ketorolac for Acute Pain, and this is a good summary of all the pharmacology about the drug. If you give Ketorolac IV, you can reach a peak serum concentration in 5 minutes. But if you give it IM, it's about the same as oral administration. In fact, it's almost exactly the same. There's very erratic absorption if you give Ketorolac IM. For all the different drug routes, the half-life is about 5 to 6 hours, so pretty long compared to narcotics, which we know have relatively short half-lives. The analgesic profile for Ketorolac is about the same as other NSAIDs if you look at it objectively in some different studies, and we're going to look at some of those studies. This paper says that about a quarter of the patients who are given Ketorolac IM don't get any analgesic benefit if you actually look at pain scores after they're given the drug. And they point out that the only real reason that you're going to give Ketorolac IM is that your patient can't take POs. There's really no other reason to give it intramuscularly in terms of efficacy. Now, certainly it's more expensive, as we talked about, compared to its narcotic alternatives. And certainly oral Ketorolac is much more expensive than other oral NSAIDs. In paper number 2, Ketorolac and the treatment of acute pain, the pendulum swings, talks about some of the evidence that is out there about Ketorolac, and it talks about the fact that perhaps some of the articles that tout Ketorolac are overestimating its efficacy because it's often compared to suboptimal doses of narcotics. That it's compared to 25 milligrams of Demerol or 2 milligrams of morphine, things that you would probably not give to a patient who's in moderate to severe pain, but it's compared to that, so then it looks pretty good because your narcotic wasn't the correct dose. And you'll hear people talk about a straw man comparison. That's really what a lot of these studies are when it comes to Ketorolac, and so maybe it's a little bit overestimated in terms of how efficacious it is. This paper also does remind us, though, that this drug definitely has a role in prostaglandin-mediated conditions. So certainly renal colic, biliary colic, and uterine type pain, which are all prostaglandin mediated pain syndromes, Nsaids play a real role there, and they really have a pathophysiologic mechanism that can provide you pain relief over and above what narcotics can give you. Now, certainly people that present with acute renal colic or acute biliary colic who are in a lot of pain, we know that the Nsaid, the Ketorolac, it takes a while for it to set up for you to get the real pain relief that you're looking for. So we often use a combination of an opioid and an Nsaid to combine them so that someone comes in 10 out of 10 pain, you give them your narcotic, it gets them set up very nicely. You also give them the Nsaid at the same time, which takes a little while to come on, but then by the time you get to the end, as your narcotic wears off, your Toradol is on board and you can get a much longer half-life, again, 5 to 6 hours of pain relief. So they can work very nicely together. There are some real conditions like that where it's definitely called for. Next question is, IM Ketorolac more effective than oral Nsaids? We've been referring to this quite a bit. Number 3 is a randomized controlled trial. This is a manufacturer-sponsored negative trial, which you don't see very often, where they looked at 20 adults with acute gout, and they gave them one of two things. So you got 50 milligrams of oral indocin, indomethacin, or you got 60 milligrams of IM Toradol, and looked at what their pain scores were and how did they do. Actually, at 6 hours and 24 hours, no difference. Even at 2 hours, they looked at the pain scores. In the IM Toradol group, the pain score had gone down by 68%, and in the oral indocin group, the pain score had gone down 64%, almost identical. And again, at the 6 hour, 24-hour point, no difference as well. All these patients went home with 5-day course of oral indocin, and they called them 24 hours after discharge. How did you do? Trying to compare the two groups, see if there's any kind of delayed effect of getting that IM shot. No difference at all, just the same. Number 4 through 6 look at also a similar question, and number 5 is 82 adults with acute traumatic musculoskeletal pain. They excluded people with back pain, kind of a special category, or people who were deemed to need immediate narcotics, that it would really be unethical to not give them the narcotics right now. So those people were excluded, and for those 82 adults who were left, they randomized them again, 60 milligrams IM Toradol or 800 milligrams of oral Motrin. And what was the difference there? And the fact is, they were the same. Their pain scores at the beginning, the 60 milligrams of IM Toradol, they started out at a visual score of 66, and the oral ibuprofen group started out at 65, and this one went down to 33, and this one went down to 25. So actually did a little better actually on the ibuprofen arm, but they were statistically really no different in this study here. No difference at any interval that they looked at. Of the Toradol group, 2 of those people needed rescue medications, and of the ibuprofen group, 3 needed rescue medications. They just having too much pain. Number 6 is a study that comes from San Francisco General, looks at 101 adults, very similar to the last study, moderate to severe painful conditions. They didn't tell us exactly what the conditions were, but they tell us that the 2 groups were about the same in terms of what type of conditions they had. And of these adults, they again randomized them to 60 milligrams of Ketorolac or 800 milligrams of oral ibuprofen, IM Ketorolac. And again, the pain scores look exactly the same. This group starts out at 6.8, this one starts out at 7, and they go down to 3.7, 3.8, just the same at the 2-hour mark. At that point, at 2 hours, 40% of both groups continued to report moderate to severe pain, that it wasn't helping them, 40% of both groups. And the fact of the matter is, you're not going to find a paper that says that IM Toradol is better than any oral Nsaid. There just isn't a paper out there that will convince you that it's really that much better of a drug. So it's something that for some of us have a hard time believing, but some of us know this. I'm just putting it out there. This is what the evidence says. There are a lot of side effect issues when it comes to Ketorolac, and papers number 7, 8, and 9 look at this. Certainly, if you look at the insert for the drug that is put in there by Roche, which makes Toradol, they caution you very strongly about this drug. That if you're going to use it, you have to be very careful with people who have renal insufficiency and elderly patients who are at risk for renal insufficiency. If you're going to be using this drug IV in a patient who is at risk for renal problems, or again, as they even say, over the age of 65, you should really be using a maximum dose of 15 milligrams IV, with obviously the absolute ceiling being 30 milligrams. And for the IM dose, 60 milligrams being your real ceiling for a healthy person, and 30 milligrams being for the ceiling for someone who might have renal problems or is elderly. And if you're going to give repeat dosing, you should be using the lower dosage. It's pretty clear in the insert that that's the case. Number 7 and 8 look at the renal effects of Ketorolac. Number 7 is a case report of somebody who got a single 60 milligram IM dose of Ketorolac and had renal failure. dialysis with pressors. It did reverse, but that's how serious these side effects can be for some people. Number 8 is a case report of a 17-year-old patient who with sickle cell disease who got IM Ketorolac followed by some oral Ketorolac and permanent dialysis-dependent renal failure. So these are scary. They're case reports, certainly, but they illustrate a point, which is that this is a real risk with this drug. We just did this course in Vail last week, and there was somebody there from Australia who said, definitely agreed this is it can be a terrible drug on the renal system. And in fact, they have a term for the triple whammy, somebody who's on an ACE inhibitor and a diuretic, and then you give them a big slamotoranol. And it certainly can be a renal triple whammy. How does it happen? What's the mechanism? Why does it have such an effect on the renal system? And the thought is that in the renal blood flow mechanism, there is a protective mechanism by which the prostaglandins play a big role. And this is why the prostaglandin-mediated inhibition thing plays a role. If you're at a time where you have decreased renal blood flow, like ischemia or some kind of stressful condition, you get elevation of angiotensin and these different enzymes, or different enzymes. And the prostaglandin actually counteracts some of those effects of those pressors that decrease the renal blood flow. And the prostaglandin helps you keep the renal blood flow. And if you inhibit that prostaglandin, which the Ketorolac does and the Nsaids do, then you put the kidney at more risk. And that's kind of how it works. Number 9 is a paper that recommends it for use in sickle cell pain. They point out that in their population, IV fluids plus Ketorolac was a great combination. The kids did really well. But be very careful here because of the case number 8 that we talked about, which is that sickle cell people with their mechanism of sickled cells in the circulation certainly are at risk for decreased renal blood flow. So they're already an at-risk population. So be very careful. But this is a paper that said it worked quite well in their group of people. Number 10 points out that Ketorolac is, as Billy calls it, a Black and Decker stomach wrecker, that it really does cause higher rates of GI bleeding, even compared to other Nsaids. Certainly we know that Nsaids in general cause higher rates of GI bleeding, but Ketorolac is special among the group. It really causes more. This was a big Italian study looking at 1,500 hospitalized patients who were hospitalized for upper GI bleeds. They compared them to 20,000 controls, and in fact, your relative risk for upper GI bleed was 4.4 times higher if you were on an oral NSAID, and Ketorolac was the worst of the group. That's a pretty scary number. We all know that this is true, but it's something to remember. And if you give Ketorolac IV, you're not saving anybody the stomach side effects by giving it IV than giving it PO. It still has the same mechanism of action on the gastric system if you give it IV, IM, whatever. It's the same drug. It still has the same effect. Number 11 is a paper from Stony Brook by Adam Singer, who does a lot of publishing in emergency medicine, who asked the question about what about the effect on platelets of NSAIDs. And so they asked the question about what about the bleeding time, which is really the ultimate test of platelet function. So they took 20 healthy adults, probably residents, medical students, I imagine, and they gave them a single 60 milligram IM dose of Toradol, then they measured the bleeding time to see if there were differences, controls and people who got the drug. And there in fact was a 2-minute increase in bleeding time after people had gotten Toradol. The thought is with the NSAID and the platelet effect is that it's not like aspirin, which is that aspirin inhibits your platelets for the life of the platelets. That the platelet never comes back until you make new platelets. Those platelets are gone. In fact, with NSAIDs, the thought is that you do have some reversibility there. It's not permanent for the life of the platelet, but exactly what the effect is, not sure. It doesn't affect your PT, PTT, right? Those are not tests of platelet function. But again, that's why they used bleeding time in this study to look at the effect on the platelets. Okay, Ketorolac and Headaches, which is the next little group of papers. I know that Diane talked this morning about migraines already. Number 12 is a really great paper. It talks about the placebo effect of managing headaches in the emergency department. And this is a randomized controlled trial where they gave people one of 3 things. You either got 60 milligrams of IM Ketorolac, you got 50 milligrams of IM Demerol plus 25 of Phenergan, or you got placebo, you got nothing. And they looked to see how the pain scores did with these 3 different groups. And in fact, there were no differences between the Toradol, the narcotics, and the placebo. And they point out in this paper, if you hadn't had the placebo arm, you would say, well, look, the Toradol's just as good as the narcotic. But the placebo arm did just as well. And so maybe it's more of a statement about kind of headaches and pain management with headaches and that kind of thing. But it's an important point to always look to see if there's a placebo arm where you're looking at pain medications being compared to each other. Number 13 and 14 are surveys that look at emergency physicians and what kind of choices we make about in terms of drugs that we use to treat headaches. And we're definitely all over the map, that's for sure. And I think that's probably because our headache patients are all over the map in terms of what their allergies are and what they want, the whole thing. But about a quarter of the time, we choose Toradol to treat headaches. And number 15 and 16 say, is that really a good choice? These are both head-to-head studies of IV Ketorolac versus IV Compazine. And in both of these studies, Compazine wins. Number 15 is a randomized controlled trial where they did 10 milligrams of Compazine versus 30 milligrams of Ketorolac. And again, Compazine wins. Ketorolac group had a few patients more that needed rescue meds, and the conclusion that with Compazine was better. Number 16 is pediatric migraine, and also has the same conclusion that Compazine is preferable to Toradol as a medication for pediatric migraine. And number 17 is just a reminder about headache patients and pain meds. This is a little study where, not really a study, but it's sort of a report of 3 patients who all present with headache, and all were stable looking, normal neuro exams, got a non-narcotic analgesic and got better and were discharged home, and all come back with terrible intracranial hemorrhages. And the point of it is that headache is really about the history and physical. It's not about how they respond to a pain med. If they respond to Tylenol, they respond to an Nsaid, it doesn't say anything about what the cause of the headache might be. Don't be fooled that it's not really a serious headache if it got better with Toradol or if it got better with Tylenol. It could still be a very bad headache depending on what the story was like. And it's just that kind of reminder paper that just really spells out for you, here was this 60-year-old patient presents with and then here they come back with a terrible consequence. And so it's just a reminder about that. So to summarize, certainly Ketorolac is very useful for prostaglandin-mediated conditions. That's where it's the most useful. That's where it makes the most sense to use this drug. It really has a pathophysiologic reason for working in those kind of conditions: renal colic, biliary colic, uterine pain. Certainly parenteral Ketorolac is not better than any other NSAID. It has some administration issues that might be of benefit to us, but it's not a more efficacious drug than other NSAIDs. So we're not going to fool ourselves about that. It certainly has some serious side effects, renal and GI side effects that we really need to know about. We have to really think about our patients and what kind of medications they're already on, what kind of problems they've had in the past, and consider this drug carefully because it does have some very serious side effects. And are there any questions, comments about your experiences with Toradol or what you like to use it for, that kind of stuff? Comments, questions? Okay, all right, pretty straightforward then, thanks.